What are the alternatives of the testosterone therapy? Lifestyle modification, GnRH antagonist, human chronic gonadotropins, selective estrogen receptors modulators, aromatase inhibitors, and stem cell therapies are the few options for the alternative to testosterone therapies. Good afternoon, everyone. I deeply appreciate your presence today for this significant discussion. My name is Dr. Paritosh Tiwari, and I am honored to have the opportunity to shed light on this crucial topic, beyond testosterone, exploring alternative therapies for low testosterone. As we know, testosterone replacement therapy is the only FDA-approved treatment for the hypogonadism. Hypogonadism is a condition where body does not produce enough testosterone. While testosterone therapies can be effective, but it may not be suitable to everyone due to various side effects, such as potential side effects, cost, personal preferences, and medical conditions. The risk-benefit ratio of testosterone therapies has been recently questioned through 3 widely publicized studies, 2 large retrospective studies, and 1 small prospective, have brought into doubt the cardiovascular safety of testosterone replacement therapy, despite prior studies suggesting that testosterone replacement therapy might be beneficial to the cardiovascular system. Let's see the studies. A systemic review and meta-analysis of placebo-controlled randomized trial was trial to testosterone therapy and cardiovascular events among men found that exogenous testosterone increased the risk of cardiovascular-related event with the corresponding implications for the use of testosterone therapy. Another study, this is a randomized clinical trial, was conducted to find the association of the testosterone therapy with all-causes mortality, myocardial infarction, and stroke among men, and to find out the association between the underlying coronary artery disease. And this study was stopped prematurely due to adverse cardiovascular event associated with testosterone replacement therapy. Another study was published in the New England Journal of Medicine to assess the association, to determine the adverse event associated with testosterone administration. This study was done in the elderly population and found that the men who received testosterone therapy compared to men who received placebo had higher risk of cardiovascular event. So, not only cardiovascular events, adverse event, exogenous testosterone replacement therapy also lead to negative feedback on hypothalamic pituitary axis, causing suppression of endogenous testosterone production and spermatogenesis. So, testosterone replacement therapy is not a good option for the men wishing to preserve their fertility. And testosterone replacement therapy also increases the prostate-specific antigen change in the lipid serum, polycythemia, and gynecomastia. So I can say testosterone replacement therapy is not good choice for the men who are having such medical conditions. So these slides remind me, when your medication causes more side effects, it's better to remain with the disease, not die due to the side effects of medications. For decades, testosterone replacement therapy is the only FDA-approved treatment for the hypogonadism. But recent guidelines for approval all are based on the testosterone restoration therapies, means normalization of the testosterone level, not only symptomatic improvement. Here, testosterone replacement therapy and testosterone restoration therapies are the two different approaches to treat the men who are having low testosterone level. Testosterone replacement therapy, we give exogenous testosterone or synthetic testosterone to replace the natural testosterone produced by the body. In the testosterone restoration therapy, we induced or stimulate body to produce their own testosterone rather than relying on the synthetic testosterone. So these two therapies are totally different. I like to compare this with the diabetes. Hypogonadism and diabetes, we can see that both are the hormone deficiency syndrome. In diabetes, type 1, insulin is the only universal option, but type 2, there are different drugs are available. Insulin, insulin secreting agents, and insulinogens are available in the market to treat type 2 diabetes. But why there is only testosterone replacement therapy for the hypogonadism? We know that 85% cases are the hypogonadism cases are the secondary hypogonadism. And in the hypogonadism cases, hypogonadism not due to totally absence of or absolutely absence of gonadotropin level. Here the only gonadotropin level is low, not totally deficient. So my question is, why only testosterone is the only treatment for the hypogonadism? We should explore other options in upcoming slide. I will try to explore or find what are the other options by which we can store our natural testosterone, or we can stimulate our body to produce endogenous testosterone. So, coming before treatment, we should know what is the primary hypogonadism and what is the secondary hypogonadism. Primary hypogonadism is a dysfunction in which testicles are not able to produce testosterone, or the defect is found in the testis. But if we see in the secondary hypogonadism, the disturbances in the hypothalamic pituitary gonadal axis are the disturbance in the communication system of brain to the testicles. So, what are the alternatives of the testosterone therapy? Lifestyle modification, GnRH antagonist, human chronic gonadotropin, selective estrogen receptors modulators, aromatase inhibitors, and stem cell therapies are the few options for the alternative to testosterone therapies. Lifestyle changes. What are the lifestyle changes? We can slide lifestyle changes that can significantly impact our testosterone level. That included the exercise, yoga, sleep, and weight control. Diet should be balanced. Diet should contain adequate amount of protein and fat. Diet should also contain vitamin D, zinc, and magnesium in appropriate amount. And diet should be not too much calorogenic, and not nowadays ketogenic diet is promoted. So crash diet is also not suitable for the patient who are having low testosterone level. Diet should be balanced, and calories should be also balanced in our diet for the proper production of testosterone. Exercise can increase the testosterone level in the body. Studies have shown that engaging in the high intensity resistance training such as weightlifting or interval training can lead to increase in the testosterone production. Regular exercise and physical activity have been found to contribute overall hormonal balance in the body. Lifestyle modification program involving aerobic exercises and diet modification significantly increases mean testosterone level. Individual who lost greater than 10% of weight showed significant increase the testosterone level. Improvement in sleep, adequate sleep also improve our testosterone level, and it's provide a good option medication-free alternative for the testosterone replacement therapy. Decreased stress management is also a major contributor to for the hormonal imbalance. By managing our chronic stress, we can lead to increased cortisol level, which can interfere with the testosterone production. Managing stress through the practice such as meditation, exercise, adequate sleep can help to restore your hormonal balance. So, GnRH analog, pulsatile GnRH treatment has been restored the fertility in patients with the central hypogonadism and intact pituitary function. GnRH therapy is administered in the pulsatile manner by a subcutaneous pump every 2 hours. Pulsatile GnRH therapy is expensive and requires experience and specific pump material. Outcome of GnRH therapy are the same as the gonadotropin therapy. So, GnRH is no longer used in the routine clinical practice. So, gonadotropin. Human chronic gonadotropin is a placental homologue for the luteinizing hormone derived from the urine for the pregnant women, are produced in vitro by using recombinant technology. SCG has similarity to luteinizing hormone. SCG can be stimulate testosterone production by testicular leading cells. SCG is used to induce and maintain the spermatogenesis by increasing the intratesticular testosterone production. SCG is also FDA approved for the secondary hypogonadism, but not primary hypogonadism. Advantage: SCG stimulation stimulate the testicular growth. the greater the stability of testosterone level and fewer fluctuations in the hypogonadal symptoms, stimulating enough intratesticular testosterone to allow the initiation of spermatogenesis. Aromatase inhibitor are the another drugs which are used for the alternative of the testosterone therapy. This act by blocking the aromatase enzyme. AI inhibition lower the estradiol level and inhibit the negative feedback of estradiol on the hypothalamic pituitary gonadal axis. Inhibition of aromatase enzyme increases the gonadotropin releasing hormone. LH and follicle stimulating hormone levels subsequently increase the serum testosterone level. Examples are the estradiol and letrozole. Most of our gynecologists use these drugs for the infertility purpose. And selective estrogen receptor modulator. Selective estrogen receptor modulator has antagonistic effect on the estrogen receptors of the hypothalamus and the pituitary, thereby increasing the endogenous gonadotropin releasing hormone, LH and follicle stimulating hormone, increasing the endogenous gonadotropin level which stimulate the testosterone production. For example, clomiphene citrate, inclomiphene citrate and tamoxifen. These are drugs we can use to in place of alternative to testosterone therapies. Stem cell therapy, in which cell lineage can be re-established human body to produce testosterone normally, would be the ideal choice for treating the primary hypogonadism. Stem leading cells, mesenchymal stromal cells, pluripotent stem cells and fibroblasts are newly discovered source of leading cells. So stem cell therapies are the new hope and futuristic treatment for the hypogonadism. So what are the limitations why we are not using these therapies? Due to the limited research, lack of regulatory approval, low efficacy and physician's preference. At last I told that testosterone is FDA approved drug. SCG, human chronic gonadotropin, is approved for the secondary hypogonadism, but all other drugs, estradiol, letrozole, clomiphene citrate, inclomiphene citrate and tamoxifen, we can use offline. These drugs are not approved by the FDA, but our gynecologist and andrologist uses these drugs for the infertility purpose in their routine clinical practice. Thank you.